A 68-year-old patient presents to the emergency department with palpitations, shortness of breath, and dizziness. The patient has history of hypertension and diabetes. On examination, the patient's blood pressure is 90 by 60 millimeters of mercury and the heart rate is 160 beats per minute. What is the most appropriate next step in the management? We have the options: initiation of carvedilol, administration of anticoagulation therapy, immediate DC cardioversion, and observation and reassessment in a few hours. Now look at the ECG. What does the ECG show? ECG shows irregular RR intervals, right? So this indicates that the patient is having atrial fibrillation. So the answer would be, since the patient is hemodynamically unstable, the answer would be immediate DC cardioversion. That is a single point to note. But let's look at the management of atrial fibrillation in brief. In a patient of acute atrial fibrillation with rapid ventricular rate, if the patient is hemodynamically unstable, that is, blood pressure less than 90 by 60, or a signs of shock or ischemia or end-organ hypoperfusion, or severe pulmonary edema, any of these if present, you consider that the patient is hemodynamically unstable and do an urgent DC cardioversion with conscious sedation. Along with that, you should have given already a parenteral anticoagulation before giving DC cardioversion. And after the cardioversion as well, what you will do is you will give anticoagulation for the next 4 weeks. Post 4 weeks, now it is the time to decide whether you should give long-term anticoagulation or not based on the CHA2DS2-VASc score. Assess the atrial fibrillation duration. If the duration according to the patient is less than 48 hours, wait and watch for 48 hours, see for the spontaneous resolution of the atrial fibrillation. If it doesn't, then you can perform cardioversion. But if the duration is more than 48 hours or the patient is not able to tell you for how long atrial fibrillation has been, what you can do is, you should actually do a trans-esophageal echocardiography to rule out left atrial appendage thrombus. But if it is not available in your hospital, then you can give 3 weeks of anticoagulation before cardioverting the patient. After 3 weeks of anticoagulation, do a cardioversion. On the other hand, if you have a trans-esophageal echocardiography available at your hospital, do it and rule out the intracardiac thrombus. If the intracardiac thrombus is not there, then you can do cardioversion. Post-cardioversion, give anticoagulation for 4 weeks. And after that, decide upon the long-term anticoagulation based on the CHA2DS2-VASc score. This is the gist of the management of atrial fibrillation. If you have any doubts, comment below.